Welcome, everyone. We're going to get started. Hello. My name is Juliana. I am one of the session moderators for today. Annie is our other moderator. Today's Lunch and Learn is titled, sorry, I can't remember the whole title. It's very long. Risky Business, Psychosocial Interventions for High-Risk Behaviors. So our wonderful speakers are going to be talking about some of the high-risk behaviors our patients with CF engage in, and some interventions that they've used to help, mitigate the effects of those behaviors on their CF care. Today's session is recorded, so if you have questions, you can either put them in the app, or please try to come up to the mic if you have questions. We do have a couple of empty seats here and there for those of you who are sitting on the floor, but we appreciate you being here, and I think we'll get started. So our first presenter is Marcy Johnson. She received her undergraduate degree from Miami University of Ohio and her master's in social work from The Ohio State University. Marcy has worked in the mental health field for several years, in addition to working as a medical social worker for Nationwide Children's Hospital. Currently, Marcy works as a mental health coordinator for the Adult Cystic Fibrosis Center at Nationwide Children's Hospital in Columbus, Ohio. Marcy is involved with several research studies involving mental health and cystic fibrosis. Marcy also provides clinical care to patients in the Cystic Fibrosis Center through brief interventions, supportive care, and coordination of mental health services. So here's Marcy.
I'm so excited that this podium is as tall as me because you really can't see me now.
But we can.
No.
Down a little.
Can you guys hear me okay though, since I'm so short? Okay, I will, let's see if we can adjust this. But yes, can you hear me now a little bit better?
Maybe if you come this way a little bit.
What about like this? Is this better? Okay. I will, how about that? Is that a bit better? Okay, all righty. Does it move? What did I do wrong? Of course, it's me. This one? Is it a clicker? Do we have a clicker? Here, I'll use the clicker. Okay, all righty. The clicker is not working. These are my worst fears coming true right now, everything.
Let's see. Okay, there we go.
All righty. Again, my name is Marcy Johnson. I work at Nationwide Children's Hospital in Columbus, Ohio, and I have nothing to disclose for this presentation. And this is just a very brief snapshot, little lovely picture of Nationwide Children's Hospital. We're located in Columbus, Ohio again. This is just information for the Adult CF Center, so there are going to be slightly different statistics or information for the Pediatric CF Center. But we have approximately 275 adult patients. We have 4 adult providers, and we have a pretty broad multidisciplinary staff. So the first case I'm going to talk about is a 22-year-old female, and I have just some brief little bits of information on some of the different areas for her. So I'm just going to hit on a couple of the big ones. From a family perspective, there is a lot of mental health and alcohol drug issues in her family history, and there's not a large supportive family for this particular young individual. From a physical health perspective, this individual was not started on ETI until 2022, but has a history of frequent exacerbations and admissions, and oftentimes when admitted to the hospital would leave AMA. Resource-wise, the family was very resource poor, as well as individually when she was living on her own. From a mental health perspective, she has a history of substance abuse, history of anxiety and depression, and trauma history as well. Some just individual factors or things to take into consideration. She does have her high school diploma and has taken some post-high school classes. I just learned recently from the social worker that she kind of recently got some new certification, so that's kind of exciting. And she does kind of wish to get involved with the mental health system in some way to kind of work in some capacity as a mental health provider in the future. So I think the key things that when I look at the history of this case, the strong family history of alcohol abuse and dependency in both parents was significant. Father was incarcerated, and the patient herself was raised at times by her grandparents. She spent different portions of her childhood outside of the home. She was either in treatment programs as a young, apologize, not as a young adult, but as a teenager. She was involved either in treatment programs that were alcohol, drug related or mental health related. And in 2022 is kind of when we noted that the drug use was starting to escalate with this patient. She was hospitalized several times and was eligible for Trikafta, but we were not able to start her on Trikafta because of her significant alcohol drug use. She wasn't in a position where she would have been able to come regularly to the clinics for appointments and just wasn't able to be adherent at that time. 2021, she had a very significant and prolonged hospitalization. She was actually inpatient for 5 weeks. And during that time, she was clean and stayed clean, but unfortunately, when she left the hospital, I think she used immediately. So probation was also involved at this point. She also was involved in several alcohol drug programs in 2021 in her community, but she continued to struggle a lot with addiction issues. And from August 2021 to July of 2022, she was in and out of jail in the hospital. And also at the end of 2021 is when she was switched to our adult center. So prior to this, she was involved with our pediatric program, but she was switched to the adult program at that time because her issues had kind of evolved to the point where the pediatric team felt she would be better served by the adult center. Probation was involved, her issues becoming more complex from a social standpoint. In 2022, she had her first outpatient appointment with us in over a year at that point, and we were able to start her on Trikafta in September of 2022. She had been sober when she first presented to us. She'd been sober for 4 months at that point, and she was living in a sober living house. We developed a plan with her so that she could start Trikafta. We asked a lot of things of her in terms of we needed to see her regularly in clinic. In fact, I think we were asking her to come in every couple weeks or so. It was very often that we were asking her to see us so that we could kind of monitor her, check in with her, and be a support to her during this time. Unfortunately, by December 2022, she had relapsed again. And so a lot of 2023, in fact, in February 2023, she went to court and was sentenced to 11 months in jail. And in just this past August, she was released. These are some of the strengths, the things that kind of make her, the things that we kind of really tried to build upon or look at as strengths for our team to use. She had very, very strong relationships with members of the CF team. She had been seen at our center since she was a young child. So some of the nurses and one of the social workers, she had very, very strong relationships. And those were the individuals that she called and reached out to regularly when she just kind of was ready to re-engage with us. She's a very hard worker. She's someone that I know that when she is looking for a job, she always finds a job. She can always find a job, but she's sometimes struggled a little bit with keeping those jobs. She has good insight into her mental health and has always been willing to seek out mental health services. Some of the challenges for this case, a lot of it had to do with geography, where she lives at. She doesn't have, I think as I'd mentioned before, she doesn't have a great support system. Her dad was incarcerated, although I do think he recently was released. And mom herself is heavily involved in the alcohol drug system as well there. Grandfather, who was her largest support, actually moved to Texas. And so that was a real loss for her. Geography-wise, she lives in a very, very small community. And because there are only so many alcohol drug resources in that community, and mom lives in that community as well, they knew mom first and knew mom's alcohol drug history. So when she became involved and started utilizing these alcohol drug resources, it bothered her. It bothered her that everyone knew her mom and her mom's history, and now was looking at her and her history. And it just, for her, that wasn't something that she wanted to find different resources, but another challenge came into play, which is transportation. So she wasn't really able to leave the alcohol drug community and where she was at because she had no transportation to get to another city or another area to kind of explore some of the resources out there. Medical appointments were a challenge as well as mental health. Because again, the resources in that community were so small, she's already kind of tested out a lot of the different resources there. Limited resources in terms of concrete needs also what did I just do there? I'm so sorry, everyone. See, this is why I should not be in charge of this sort of stuff. There were also some challenges when she was in the sober living program that while she was there. There were boundaries with some of the male staff that worked there. She had her medication stolen by other individuals that were participating in the sober living program. She had challenges with getting into appointments. She had a lot of times had to rely on a sponsor to kind of help her out. And then medications themselves also became a barrier on many levels, not just at sober living in terms of them being stolen, but also in terms of the jail and prison system and getting access to medications and having them when she needed them and them being provided. In fact, there were times when she went without medications for a short period of time while we coordinated with the jail and prison system to make sure that they were provided. So this is kind of the area where we kind of were figuring things out as we went along. We didn't really have there was no clear thing out there like if your patient is in jail and has CF, this is what you should do. So it was certainly challenging. We had a strong multidisciplinary team approach. So myself, from a mental health perspective, the social worker, the nurse, the physician, the pharmacist, everyone was really heavily involved in creating a plan for her and helping her. One of the things that I think really worked well for this patient, in fact, she kind of said that to us, is I just need to take things day by day at this point. So we really try to meet her where she was at. We had a lot of regular meetings. In fact, we meet weekly to talk about our patients and our high need patients and what we can do to support them and or what we need to do to prep for them in terms of when they're coming in or who needs to reach out and do what for our patients. So those were the things that kind of worked really well. Sober living itself as well was in some ways a challenge, but I also want to say that it also was a strength. There were a lot of things about the program and the structure it provided that was also helpful for her. Although again, it's kind of balancing out what are the things that are challenging there and what are the things that really do provide good structure for her. Here is a brief overview of a second case that actually is very, very similar in some ways. You'll see some of the same issues that I'll kind of talk about again, here's a brief overview of the case. Family, very, very strong history of alcohol, drug abuse, and dependency, and the parental figures in this case, physical health perspective. This patient was on Trikafta starting in 2020, but she actually had a lot of issues staying compliant with Trikafta. Legal system, even as a teenager, she had some involvement with probation, and then again as an adult as well. Resource-wise, mom and stepdad actually are a good resource to her, but there is also a history kind of conflict with mom as well too. From a mental health perspective, she had a strong mental health history when she was a teenager. When I initially met her as an adult in our center, her mental health was fairly stable, but became unstable again as things progressed. Again, some kind of repeated some information here. There's a family history of alcohol, drug abuse. There is some trauma history as well with this patient. This patient did not necessarily disclose it to me, but I was aware of the history. When I first started working with her, she was very stable. She had been in a committed relationship for years, but things kind of started to kind of fall off for her when she broke up with her boyfriend in 2020. And I think he was a lot of the source of stabilization for her. He had a steady job. I think that provided stable housing and a stable situation for them. But when she broke up, she struggled herself with keeping a job, where to live. She lost her transportation, and she lived with mom for a short period of time. But again, that wasn't something that, due to conflict between her and mom, she was not able to stay there. She had several hospitalizations between 2021 and 2022, and her health started to decline. And part of it was partially because she wasn't taking Trikafta regularly. She was homeless. She was moving from place to place. She didn't really have, she was living out of her car at a period of time. And so I can see why taking Trikafta and being compliant with it was really difficult for her. She also wasn't always able to keep a job because she was homeless. And so that also too contributed to a lot of the issues. Her first lengthy incarceration was in 2022 from April to June. It was drug-related, and then arrested again in July 2022, and then incarcerated in a new jail system. And she is still currently incarcerated and not eligible for release until 2025. This case is a little different because in this particular case, the patient kind of fell off for us. We actually had very, very limited contact with her, and because of that, we wanted to draw upon the strengths for this particular patient, as well as we do with with all of our patients, but it was harder because we didn't actually have as much contact with her. We would regularly reach out, but we weren't able to actually get in contact with her. But mom actually was a huge advocate for her, and even though mom and patient have history, mom does love her daughter and was very concerned about her. So she did regularly reach out to us. She was involved. She helped facilitate a lot of conversations between the jail system and between herself and patient as well. And just like our other patient who kind of has benefited from the structure that unfortunately some of these systems provide, she has actually, I think, done okay in jail in terms of having some structure. She's regularly eating 3 meals a day. I think from what I understand from mom, she's gained some weight and is doing pretty well from that perspective. Challenges in this case, lack of contact with the patient made collaboration really difficult. She had some of the traditional concrete barriers like transportation. Mental health concerns remained untreated. I think in all the times that we've tried to reach out to her to help out and assist, she just wasn't able to actually tackle any mental health issues or even seek out treatment. I'm not actually sure. Even all the alcohol drug treatments she explored because we just didn't have enough contact with her to know what she had tried or what she hadn't tried, because we didn't see her for a very long period of time in our clinic. We actually as well had some challenges working with the adult hospital. So at our particular center, we have a pediatric and adult outpatient services, but the inpatient hospitalization is only for the pediatric patients. So our adult patients go to another adult hospital. And in this particular case, we had a lot of challenges in working with the adult hospital communication, and patient just had a lot of issues in terms of feeling like she was treated equitably and fairly there because of her alcohol drug issues. And there were also medications and medical complications that happened with her as well. One of the things that I think with both cases was trying to figure out medications and the jail system versus prison system, because they're two completely different systems, and trying to figure out who provides the medications, how to get the medications. Most of the jail systems won't provide them. Some of the prison systems will. It's just been a challenge kind of figuring that out and then communicating with those actual systems. Who do I talk to? How do I facilitate this? All of those things have made it a little more challenging. Similarly as last time, a few of the same things worked really, really well for our team. We had a multidisciplinary team approach. We had a lot of regular meetings and regular communication as a team. This mom, although like I said, mom is an amazing advocate for her daughter, mom did try to do a little bit of kind of working in between staff. But one staff member, she'd call and be like, I would like compassionate release for my daughter. And then she'd call another staff member and say, I heard something about this compassionate release program and all these different things. So I think she was trying to feel out several different team members to see who would be willing to sign off or help her out with this process. And so because we meet so regularly as a team, we were able to kind of have that discussion as a team and whether or not that was something we could help out with, or even if it was appropriate for us to provide that sort of direction or release for her. So I think the big overall takeaways that I kind of take from this is that there is no handbook on how to best provide care for these cases when we're navigating these legal and penal systems. They have their own rules, and oftentimes they may appreciate our input, but they might very gently say that thank you very much for your input, we're still going to do it this way. And so it can be very, very difficult. Jail and prison systems are each their own different systems with their own different rules as well too. And there's no magical situation for these really complicated cases like this. So Some of the things that I myself have kind of thought of is early identification of alcohol drug issues would have been helpful. For me, from my perspective, the earlier we can intervene, the more helpful. But these cases are complicated because when individuals are involved with alcohol drug issues, a lot of times they are avoidant and they don't come to clinic and they don't want us to know what's going on because they do have relationships with us at our center. They've known us for years. And so it makes it, I think, it makes it very complicated. I think trauma history, mental health history, knowing all those things as well is very helpful and trying as early as we can to provide intervention and help. And I also wanted to give a shout out to Jody, the social worker, in these cases because she is truly, particularly in the first case, she truly is a great resource. She has known this patient for years. The patient is very highly trusts the social worker. And so a lot of times, although I was the mental health coordinator, really truly it was Jody, the individual, who was doing all of the behind the scenes coordination of all these different things. So truly without the whole multidisciplinary team, I don't know if we could have navigated these cases as well as we did. Certainly not perfectly, but as well as we could. So. And any questions?
So we invite anyone who has any questions to come up to the microphone, or you can send anything through on the app if you have any. Now, they don't have to be questions. If you have comments or even shared experiences, even some suggestions on any work that people have had within the penal systems and the jail systems in the past that we can all take home as using in our own practice.
Yeah, I love suggestions, so anything.
I wonder, Marcy, if I can ask you a question. Oh, we have someone here.
Were you able to facilitate any clinic visits while the person was incarcerated?
No, unfortunately, in the prison system, the way they do it, they coordinate their own medical care and they have contracts with their own medical facilities. So they do not come to our CF center. They will consult with us about some of the CF aspects of the care, but they have their own, at least in our particular state, that may differ again in different areas how they handle it, but they have their own contracts of where they will take patients for care.
Yeah, I have a couple of patients that are incarcerated, but we were able to provide you writing a letter, prison, to have PFTs and get the tests done, and they do bring them quarterly to see us.
That's great. Yeah.
I was just going to ask Marcy, it sounds like very complicated cases for you and your team. I wonder if there's ways that you as a team manage your own self-care around all of this.
You know, I think that we all have individual ways that we handle and manage the stress of dealing with complicated cases like this. Certainly humor is one thing our team uses as well too. We're a great team. We get along really well, and it's wonderful knowing that with these complicated cases that we can kind of talk about them together and kind of collaborate with them together. So that has made the difference. I think that we all at our centers may have experienced different types of cases that are complicated, but we do not on the team always see eye to eye, and it can make it sometimes hard to kind of navigate those cases. In these particular cases, I think we were pretty unified and how can we be compassionate and caring, but also recognize the fact that some of these things happening are natural consequences. We can't take away some of the legal consequences for what has happened. As much as we may want to, it may not even be the most appropriate or even best thing for the patient to do.
Thank you, Marcy.
Okay, thank you.
So I'm just going to introduce our next speaker. Her name is Amy Nestor. She received her Master's of Social Work from Boston College in 2002 and previously worked as an inpatient case manager at UNC for the last 10 years. Since 2020, she's been working in the UNC School of Medicine as a CF social worker. Outside of work, Amy enjoys spending time with her family, traveling, reading, and birdwatching. Welcome, Amy.
We had to get the right presentation up. Okay, so this presentation is Substance Misuse, a Harm Reduction Approach, the journey of a patient and her CF team. Why is this not doing it? And I'm really not good at this technology thing, so there we go. I have no relationships to disclose, and here are the objectives quickly. Y'all know them, so we can scroll through. So I am one of the adult CF social workers at the University of North Carolina in Chapel Hill. We have about 360 adult patients, and they come from all over North Carolina, and we have patients from other states as well. We have a robust multidisciplinary team. We've got pulmonologists, nursing, social work, dietitians, pharmacy, respiratory therapists, psychiatrists, and research coordinators. And a little bit more on this later, but we do have a behavioral health care management program, and that focuses on short-term therapy, typically 6 to 12 months. And it is generally what we are treating is mild to moderate depression, anxiety, grief, and adjustment issues. So our patient is a 40-year-old female. She has a 13-year-old daughter. She has CF with CFRD, also on Trikafta and using Home O2. When I first met her, her FEV1 was 34.1% on January 28th in 2021, and it dipped as low as 23.9% in April of 2021. Also a history of chronic pain, history of trauma, diagnosis of depression, generalized anxiety, and opioid use disorder. And she was on multiple psychiatric medications for mood, anxiety, sleep, including an antipsychotic. So my first impressions, the first time I met her was she was hospitalized for a CF exacerbation, and COVID was still going pretty strong. Not that it's gone now, but it was early 2021. So I talked with her on the phone for the first time. She was getting ready to be discharged, and she was pretty distraught. She was unhappy with her current buprenorphine provider, and she was in the process of trying to identify another person to provide the medication-assisted therapy and her behavioral health medications. She was very distressed about having to discharge home because she lives with her mom and her grandmother and her daughter, but also her mom's sister and the patient's two nieces had also recently moved into the house, and the aunt was also actively using opioids. So, and she had begun using again after a period of about 2 years of sobriety. She had been going to a mental health center in her area, but had stopped going because she was made to do classes 3 days a week online, and they only had one computer in the house, and she didn't have a private space to do the classes because there were so many people living there. So she didn't want to do it anymore, and so she was trying to find another provider. So this was kind of what was going on when I first met her, and so from there we began our journey together. Our initial interventions, we made so many referrals to community mental health agencies and pain clinics. From March until June of 2021, I called at least 5 different mental health providers. I gave her a bunch of numbers to call. And she really wanted to be seen in person. We wanted her to be seen in person, and we wanted someone with substance abuse expertise. And, a lot of agencies didn't take her dual insurance. She had Medicare and Medicaid, so they would take one but not the other. Mental health is difficult these days, as most of you know, so there were really limited providers, and a lot of places didn't have any appointments, or they didn't do the medication-assisted therapy and the behavioral health medications. They would just do one or the other. Also, her own non-adherence was, a concern. And one thing I just made a note of was also, so this was in 2021, it was a lot harder to find providers to prescribe things like buprenorphine because people had to apply for a special federal waiver, and there were limits on how many patients you could treat. And that changed in June of 2023 when Congress passed this Patient Consolidated Appropriations Act. So providers no longer had to apply for the waiver, and there were no longer limits on how many patients you could treat. But that didn't help us in 2021. So, and I also have on here, in November, we finally made a referral to UNC's outpatient substance abuse treatment program. That was kind of a last resort because it was going to be telehealth. And she lived in Eastern North Carolina, and this was telehealth, or it was in Chapel Hill, and that wasn't particularly convenient for her. So one of our big turning points, probably, the biggest intervention was in June 3rd to be exact, 2021, our consulting CF psychiatrist agreed to prescribe buprenorphine for her and her other behavioral health medicines. And this was really a strategy to reduce harm. She was not our typical behavioral health care management patient. She had complex mental health needs, high risk of overdose, risky substance use. And in our typical model, our psychiatrists will provide recommendations to our pulmonologist, but it's typically the pulmonologists who are prescribing the medications. So the psychiatrist may see a patient once or twice, or they do an e-consult, but the onus of prescribing the medication then gets shifted to the pulmonologist. And she was on a lot of medications that our pulmonologists were not going to be comfortable prescribing, including the buprenorphine. I mean, they don't do that. So, and our psychiatrists don't follow patients longitudinally. But in this case, they finally said, you know what, we'll do it. We'll treat her. We'll provide the medication-assisted therapy. We'll provide her mental health medications because you all are trying and we can't find anything for her. So that was really the turning point of, or the beginning of the turning point. And in this slide, I've just talked a little bit about some of the consequences of her substance use. So between January 2021 and March 2022, she was hospitalized 6 times for CF exacerbations and her substance use. Her FEV1 dipped into the 20s. In March of 2021, she was found using heroin during one of her hospital admissions. And someone walked in on her. And I do outpatient social work. And so the inpatient case managers, follow her while she was inpatient. But we communicate with each other. And the social worker inpatient was asked to make a child protective services report by someone on the team. And she really didn't want to, and she called me and we talked about it, and she made the report. But then they didn't open the case, but I first met this patient in August of 2021. It was a group effort. She was coming on a non-clinic day. She needed a 6-minute walk. Our respiratory therapist was instrumental in getting her here on a different day than our normal clinic day. And it was all worked out. And the patient was apparently highly stressed because people talked with her throughout the day. She kept getting lost. She was saying she didn't know where she was. She showed up 2 hours late, obviously impaired. Her speech was slurred. She didn't really know where she was. She was kind of behaving bizarrely. One of the nurses had left clinic and found her in the parking garage, basically asleep. And kind of woke her up and called us up, called clinic and said, hey, she's here in the parking garage. So at that point, I then made a CPS case. She got examined in clinic. We couldn't do the 6-minute walk. She was admitted to the hospital for CF exacerbation. She was positive for fentanyl. And she had driven her 13-year-old daughter and her 15-year-old niece with her. So that was the reason for the report, was that she had them in the car with her and had driven them there and, put them in danger. So that was in August of 2021. And then in October of 2021, she lost her driver's license after she got in a car accident while intoxicated. She rear-ended another car. Apparently, and she's very honest about this. Told me the whole story. Nodded off. The car that she hit apparently had to pull her parking brake because her car kept moving. Her mom had realized that she had left the house and was going to get drugs, so found her at the scene of the accident, took the drugs out of the car so she wouldn't get a possession ticket, but she got the DUI. And so, if you remember, we've been prescribing the buprenorphine for her since June of 2021, but she continued to struggle with using despite having those medications. So, and when we chose, when we decided to start prescribing for her, we had some guidelines. She was going to have regular telehealth visits with the psychiatrist, and she had to agree to tox screens. When we told her, it doesn't mean we're going to take away this medication if you're positive. It's just a discussion. If you're positive, it's not okay, but we want to know. We also wanted to know that she was taking the buprenorphine. The prescription was only written for 30 days at a time. She and I were checking in regularly. I was continuing to encourage her to do Narcotics Anonymous or engage in some sort of outpatient substance abuse treatment. We all communicated on our team. There was consistent communication with all team members so that everybody knew what her plan was, what she was supposed to be doing. And then after the car accident, she was in the outside hospital, was positive for fentanyl, not positive for buprenorphine. She had also filled the buprenorphine prescription that day, and half the bottle was missing. So they had thought that, she had diverted it. So at that point, the psychiatrist began to only write her buprenorphine script for 1 week at a time. So, and again, she between when we started prescribing in June and even as late as February 2022, she was admitting to using at least 3 times a week. She was positive at every hospitalization for fentanyl. She also was positive for buprenorphine, to her credit, near the end, but she was always positive for fentanyl. And again, she was honest about it. She would say, I'm still using about 3 times a week. And so still wasn't getting any other treatment other than the medication. So our big successes were after she showed up to clinic with the 2 kids in the car and CPS was called. They did open the case. She agreed to go to substance abuse treatment from the hospital, and she was in substance abuse treatment for 3 weeks. And then in March, after a pretty prolonged hospitalization, at the end of March when she was discharged, she agreed to go to another substance abuse program, and that one she stayed for 7 weeks. And that one was really, I think, the beginning of her really turning things around. And our whole team had a hand in this, from the inpatient team to the nurse and the respiratory therapist and the pharmacist talking with these treatment centers because they don't know how to deal with CF. And she was a complicated patient, and she was on oxygen. And so there was a lot of communication. Our psychiatrists were communicating. And when she left that program after 7 weeks, they finally were able to connect her to a community mental health center that could take care of her psychiatric medications and the buprenorphine. So that was all a success. And she was so upbeat and proud of herself when we would talk with her. And in August of 2022, she got a part-time job. She was active in Narcotics Anonymous. She'd gotten a sponsor. She had gotten her driver's license back. Her and her daughter were working on repairing their relationship, and she was 5 months sober. She had also met some millionaires in Narcotics Anonymous and took her, I don't know that it was her first, I think it may have been her first airplane ride. I can't remember, but they had a private plane, and she rode on their private plane to Florida. It was her first time in Florida. And I just remember thinking, only you could meet millionaires at Narcotics Anonymous and go to Florida on a private plane. And she has this big personality. She's fiery and sassy and smart, and she says exactly what she thinks. You never had to wonder, how does she feel about something? Because she'd let you know. And everybody on the team, has these stories. I have only been working there since the end of November of 2020, but so many people have known her for so long, and they always had these great stories about her. So things were looking up. And then bittersweet. So on October 25th, she came to clinic, and that was the last time, most of us saw her. She'd gained weight. She looked great. She was talking about she was going to go to the Grand Canyon. She wanted to take her daughter to Florida for a concert for her 16th birthday. That would have been this past June. She had 7 months of sobriety. She was no longer on buprenorphine, and she was so proud of herself. And then on November 10th, she was admitted to the MICU with the flu, and she was intubated and passed away on November 11th. And her mom was by her side, and several of us, she wasn't responsive at all in the hospital, but we saw her. And so it was incredibly sad, but I think the thing that I am remembering is that she had been sober for 7 months, and things were just so much better, and she died, and but she had, I don't know if she would have conquered it forever, her substance abuse, but she was in a completely different place, and she was proud of herself, and she was showing her daughter, hey, I'm keeping on trying, right? Things can always get better. So that, and I like to picture her. I put this picture up here because this is where I like to picture her right now, like hanging out on the beach. And I just kind of the final takeaways are that we're better together. We have such a great team, and we all worked to provide her with the best care for her CF and her mental health. I never felt alone in my work with her. I always felt supported from people just who would just listen to me talk about it and provide emotional support to the practical strategies and support. I just saw her pulmonologist, everybody, we were all on the same team. And persistence pays, even when her situation seemed impossibly bleak. She didn't stop trying to get clean, and we didn't stop providing support and treatment. And it was frustrating at times, and I know she was frustrated. We had a conversation once where she hung up the phone on me. She had a lot of things to say to me. She didn't like anything I said to her, and she hung up the phone. But we never stopped, trying. And people can always change. So that's it. That's all.
So the question I have is how you kind of balanced her CF care and her mental health substance abuse care. Because I feel like we sometimes struggle with, obviously the patient's main priorities are getting help for their substance abuse or mental health issues, but her lung functions are also bad. How do you kind of figure out what to focus on in those clinic visits? I'm guessing, trikafta enzymes and air clearance really weren't a priority at that time.
Right. No, that's a great question. And she didn't make it to clinic all that. She was in the hospital. That was where she got a lot of her CF care, honestly, because she was hospitalized so many times. So I think that the hospitalizations would kind of bolster her up, and she would get out. I think with her, it was like she was going to die from her substance abuse, I think potentially before her CF. And so I think that's one of the things that we really focused on. And other people on the team could probably speak to this better than I could. I think she was fairly compliant with her medications, her trikafta, and she had oxygen at home. And I think maybe she didn't always use that when she was supposed to, but she was fairly compliant as much as she could be. So I don't know if that really answered your question, but I think sometimes you have to kind of do what you can, and yeah.
I just wanted to add that it sounds like you developed an amazing relationship with her.
Yes.
And as a result, she kept coming back. It's not just her, it's both of you and all the whole team.
She did. And again, everybody, she was beloved by all, and she loved us, right? There was no doubt in our mind, and she had this quality of using your name a lot when she would talk with you, but it wasn't weird or didn't feel like she was trying to get anything out of you. It was just her. So she would talk, and she'd be like, Amy, blah blah blah, Amy, and it was just. Last night, a bunch of us were talking, and someone on the pediatric dietary team remembered her as a teenager and had this great story about when she got diagnosed with diabetes. And she said, well, I'm still going to eat cake as she was discharged from the hospital. I mean, just everybody, she was like nobody else. So.
Thank you so much, Amy. That was fabulous.
One more question.
Oh, there's
Yeah,
one question.
what kept striking me as you were kind of telling the story of the progression of her treatment and her care. So often I see that same trajectory. The treatment that she needed, the substance abuse treatment, the inpatient care, the psychiatric follow-up, all of that came after that huge crisis point. The treatment she needed years ago came after the crisis of driving her daughter and niece while under the influence. But I guess I'm just wondering, but it seems like your team came up with so many creative ways to put together a care plan that wasn't perfect, but my goodness, so many, the consulting psychiatrist and figuring out a way to get the
Buprenorphine. It's a tough one. I had to practice it.
Yeah. And so I'm just wondering, just how did you guys have team meetings to figure this out? Like how much conversation and what disciplines kind of came together to come up with that?
And that's a good question. And I forgot to mention with your question, I mean, we're really lucky to have this program where we have consulting psychiatrists. And so every Thursday, myself and the other social worker and the pharmacist, we meet with the psychiatrist and we go over patients. And we don't just talk about the patients that are getting active therapy with us. We talk about kind of the big mental health players, things that are coming up. And so that was instrumental because that was where at least, the psychiatrist and the pharmacist and I were talking about, okay, fine, the psychiatrists are now going to prescribe this. And then just communicating, with everybody. I mean, we have a big open clinic. And so, you just catch people when you can and say, all right, this is what we're doing now. Or we, use, I don't know if y'all do Epic, using Epic to communicate as well. We never, I don't think we ever had a meeting. But we just we're pretty good at communication, so just kind of all, that's what we
incredible.
did.
It speaks to your teamwork.
Yeah, thank you.
For the sake of time, we're going to move on. And if we have time at the end, we can ask more questions. I know everybody has other things they want to get to as well. So next up, we have Rachel. Rachel Grimes is a licensed clinical social worker and clinical therapist in the Cook Children's Medical Center CF Care Center, in Fort Worth, Texas. She has been working with the CF population for the past 5 years. She's working towards completing her doctorate of behavioral health through Cummings Graduate Institute within the next year. She received her master's in social work from the University of West Florida in 2013 and her Bachelor of Science from Elon College in 1998. She has trained extensively in trauma therapy and is certified in both eye movement desensitization and reprocessing therapy and trauma-focused cognitive behavioral therapy. She is also trained in motivational interviewing. She is very thankful to be a part of the CF community and have the opportunity to develop lifelong relationships with patients and their families. Do you want me to read that too?
Nope.
Okay.
Okay. All right, everybody, just take a deep breath. Notice what you're feeling and where you're feeling it in your body. And I'm feeling excited to talk about my favorite topic in the whole world. And I'm also feeling proud because Amy was my mentee last year and she just did such a great job. So I'm really proud. So I'm excited to talk to you guys about hiding behind the couch. I did get some support from the foundation to be here. And we're going to talk about a 9-year-old girl. Most of the work that I do, we're a combined center, is with adults, but every once in a while I do get to meet with some kiddos. So I'm going to talk about the work that I did with a 9-year-old girl. And this was several years ago when I was working with her. So I think she's about 13 now. She has an older brother who does not have CF, and the two live with their maternal grandmother. Also, the maternal grandfather is a very important part of their lives. He's remarried, and they kind of bounce back and forth between both of those very supportive homes. Mom and her boyfriend live down the street, but they are out of town for work for months at a time, not very reliable. And then the bio dad is involved very minimally. They were together till mom and dad were together till she was about 6 or 7, and then they split up. So mom travels, but the reality is she struggles with substance abuse and has been in abusive relationships, both with dad and her current boyfriend. So I'm going to show you guys a quick video. This is something I used with the Army when I was a domestic violence victim advocate. I would show the soldiers this video, and then I would tell them, put on your social work hats because I'm going to ask you a question at the end. So we all already have our social work hats on for the most part in here, but I want you guys to look at this video as if the young girl in the video was my patient with CF. Oops. No. Oh, thank you. Hey.
He only loves her when she's living in her innocence. She is lying on the floor begging, baby, please don't leave. He only loves her when she's giving up the battle she has, given up her dreams, 'cause he's the only one she needs. When the madness takes us over, this is all we'll ever be. When the silence takes us under, this is all we'll ever feel. She only loves him when he's lost a man's fight. His tears he cannot hide, and he's dying deep inside. She only loves him when he's down on his knees begging, Lord forgive me please, I never meant this love to bleed. When the madness takes us over, this is all we'll ever be. When the silence takes us under, this is all we'll ever feel. Hold on, my love. This war is love. I'd die with you. I died with you. I die for you. Oh. When the madness takes us over, this is all we'll ever be. When the silence takes us under, this is all we'll ever feel. When the madness takes us over, this is all we'll ever be.
Okay, sad, right? So before I could even stop the video, the soldiers were raising their hands because they just knew I was going to ask them all of these things that you're going to see, like all the bad things that Shane did. And then they would be dumbfounded when I was like, so what are the strengths? What are the good things about the family? So I think it's important to look at that perspective, and it was interesting to teach the soldiers about that. But imagine that little patient with CF. They're already going through so much, and then imagine having to add treatments and doctor's visits and enough food to eat on top of all of that. So this is just a little bit about what domestic violence is, defined as a physical, sexual, or psychological harm caused by a current or former partner. All of these were sort of demonstrated on that video, and a lot of them my patient was exposed to. And the one that sort of stands out the most to me is that isolation, where when you're a family with a patient with CF, you need a lot of support. And so in the video, he took her away from her family and her friends. And then also that happens with my patient's mother. You know, even though it is somewhat her choice, she's also getting isolated by going away for work. These are just a few statistics about domestic violence. It affects 1 in 3 women and 1 in 4 men in the United States. And the work I did overseas in Korea, I did find that more men were actually disclosing being victims of domestic violence. And last week, I was working with a patient who's one of our CF patients who's 22. I've been knowing him since he was a kid. And he actually disclosed to me that he was being victimized by his girlfriend of 2 years, and I had no idea. But it was really great for me to have the background that I do have working with domestic violence, because I was able to look at him from the perspective of he is the victim, and then it helped me formulate what I wanted to say to him, how I wanted to respond to him, because a lot of times people will think like men can't be victims, but they really can. Another one of these astounding statistics I wanted to point out was that the DV hotline receives over 20,000 calls per day of crisis calls of people experiencing family violence. To me, that's just astounding. 10 million children, or 10 million people are impacted, and that includes the children who are witnessing domestic violence. And of course, I had to give a shout out to my great state of Texas, where in 2019, nearly 72,000 people received family violence services through the Health and Human Services Commission. Unfortunately, nearly almost as many asked for help and were unable to get help just because of funding and different things like that. So this issue is impacting a ton of people. For the children, I'm sure none of us are surprised that they're going to be experiencing anxiety, depression, PTSD. The kids in the classroom with the stomach aches, the headaches, they need to go to the nurse. A lot of the times that is because they have been witnessing domestic violence. And of course, when you're researching something and you want to find the answer that you want, which I wanted it to say that it affects their health, it does. I found it. So I know that the title of our presentation is Risky Behaviors, and I just want to make sure that nobody takes away from this presentation that I'm in any way blaming the mother or her behaviors for the patient's struggles. Domestic violence is very tricky, very hard to be in, very hard to get out of. So I just want to make sure that nobody takes away that we're blaming this family. We wish the family situation was different, but it wasn't. So we're just sort of talking about what happened to my patient. I got really interested in how domestic violence impacts mothers. And I found that they really do blame themselves, and they will neglect their own needs to care for their children. A lot of times these moms are going to come up with those chronic health problems as well. They're having that pain, that headache, different things like that. And then I found that a lot of times the perpetrator will be encouraging the children in the home to actually abuse the mothers as well. And one of my adult CF patients that I worked for quite a long time with, he grew up in a very, very violent home situation, and his parents separated, and his dad had him thinking of ways to terrorize the mother. He would do all kinds of crazy things, but he was a kid, so we can't really make him feel too responsible because the father was the one saying, oh, go do this, go do that, go in your mom's house and change things around so that she thinks there's someone coming into the house, or go into her, put a thing on her car so we can track everywhere she goes and make her think like, someone's following her. So it's very common that the perpetrator will be encouraging even more abuse than what they're already getting. So the big old question is, why didn't she leave? And if you were like me and binge watched this show Made over the weekend, you'll see that all of these reasons are why they just can't leave. And a lot of times it's financial, or they're isolated and they have no control over finances or where they are. They can't just call their mom or whoever to come and help them. Also, when a victim is leaving, that is the most dangerous time, and it often takes 7 to 9 times to actually be able to leave. Also, when they're pregnant, that's another high-risk time. But a lot of times these moms don't want to disrupt their children's lives, and they may have a child with chronic illness that needs care, and what they think is the best thing is to just stay there. So for this patient, the state made the choice for the children to be placed with the grandmother. So when I got to meet this little sweet girl, the grandmother brought her in for the intake. And a lot of times I don't really put quotes in my documentation, but when I looked back at my notes, I was like, wow. These are the things she actually said through our sessions together, but on the assessment, she said, we've had a hard life. Mommy, please don't go out and get drunk. I wish I had better parents. So if you know me, you know that my answer to every single thing is EMDR, eye movement desensitization and reprocessing. I am obsessed because it works. So of course, I decided that this little girl should have the gift of EMDR. And by the way, my professional model is EMDR is the gift all people should give themselves. So if you haven't tried it, you should definitely try it. So if you're trained in EMDR or you've spent more than 5 seconds with me, you might be familiar with the phases of EMDR. And the phases are not linear. We can spend a lot of time in different phases. For example, the preparation phase is the resource building, where we will get the brain really ready to process the hard stuff. And a lot of people will think phase 4 is the actual EMDR, but that's actually the desensitization phase, where you are following my fingers and processing the hard stuff. But there's a lot more to it than just that. So first I decided that I wanted to see what we were really dealing with. So I did the UCLA PTSD Reaction Index for children and adolescents, and she scored a 43, which meant that she did meet criteria for PTSD. She also endorsed the dissociative symptoms. So she was the one zoning out and really just not being present. She also scored a 75 for anxiety and 83 for depression on the RCADS, and those both indicate that she is above the clinical threshold for anxiety and depression. So here's where we got to do the fun stuff. One of the first activities in EMDR could be the safe, calm place, and so I always get to give my example of the beach for myself, and I'll just be at the dentist doing like this because the dentist is not fun. But it's just a way to determine if your mind can relax. Then we agitate you a little bit, and then we see how well you can titrate between relaxation and agitation. So my safe, calm place is the beach, but this little cute girl, oh my gosh, it was a virtual visit. So she was actually at home in her bed. She put all her stuffed animals around her, and she started following my fingers. And after a few passes, I'll say, what did you notice? And she's like, I'm so cozy. Okay, go with that. what did you notice? Oh, I'm so comfortable and warm in my bed. And more and more and more of that. And I was so surprised how strong her brain was, despite all the barriers that she was experiencing and all the anxiety and depression. But she was able to make her brain so relaxed. And this was an exciting time for me because she was the first patient I ever worked with that a smell came up. When I said, what did you notice? She's like, I smell my cherry lip balm. And I was just so amazed and impressed and excited by that. So I had to put it in there. But she was able to get really relaxed and really ready to do the hard stuff. So phase 3 is the assessment. And one thing about EMDR is it's getting the left and the right side of the brains communicating with each other. So even in our assessment phase, we start to do that. We'll ask, what's the presenting issue? She wanted to target a situation where her mom and her bio dad were fighting. Then we look at the picture. They were yelling. The negative cognition, the world is not safe. We want to believe the world is safe. And it was just going back and forth. This sort of mimics the bilateral stimulation in some way. With kids, they may not always be able to verbalize their negative cognition. So definitely with her and most kids, I do kind of help them with this. So I was able to help her say, hey, the world is not safe. Does that sound right? And she agreed with that. And then when I said, hey, when you look at the picture and the words, the world is safe, how true does it feel? And she said it was about a 4 out of a 7. She felt scared and she was disturbed, a 10 out of a 10, and she felt it in her chest. And you probably won't be surprised to know that most of my patients with CF do feel it in their chest. So this is not her picture. This is my interpretation of her picture, but it's mom and dad are fighting. Dad threw a pan at mom and knocked her glasses off, and then her and her brother are hiding behind the couch. So she drew the picture to help us get the idea of what she wanted to target. She held it in front of her, and then she started with the eye movements. And sometimes people are unable to do the eye movements, but they say if you really can, try to do the eye movements because it's the best. But there's other ways. There's tapping, or I have buzzers, or people could do sound ear to ear. So she actually followed my fingers, and she was able to participate in desensitization. I was able to install the positive cognition that the world is safe, the body scan, and the closure. And with kids, sometimes it's difficult for them to verbalize the cognition, but it's also difficult for them to verbalize the different scales. So she was able to just point. I said, how true does it feel? She kind of pointed in the middle. And then when I asked her, how stressful does it feel? She pointed to the darkest unicorn. And so as I'm doing the movements with her, then we'll stop and say, what did you notice? She kind of just pointed down. She didn't really verbalize too much about like what was coming up for her, which is fine. And so she was just kind of doot, 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 till she got to a 0. And I use this a lot with kids because it's just easier for them. So then when she came back a couple sessions later, I'm like, hey, remember that fight between mom and dad? What comes up for you now when you think of that memory? And she said, my grandma keeps me safe. She's like, I'm going to draw a picture of it. So, of course, not her picture again, but she drew a picture of herself and her grandmother. And I didn't really get a good depiction of it on this slide, but those smiles were huge on that picture that she drew. So I just wanted to say that EMDR works. I love it. I'm obsessed with it, and I am more than happy to talk to anyone at any time about EMDR.
Any questions?
No?
We got one in the back.
Oh.
Do you normally do EMDR and telemed?
Oh, yeah, I can do either. I was trained in 2020, so I learned telemed, but really it works either way.
I've seen the NPR as well, and I'm a fan as well. I know, like, our pulmonologists and our RTs, many of our folks during COVID, the stress and trauma of
Oh, with my colleagues? I mean, I would love to. They beg me every day. So I have connected some of my colleagues with other colleagues because it's not really that great to do EMDR on your friends. But yes, I would if I could.
Any other questions?
Thank you.
Thanks.
And now we're going to introduce our final speaker, who's Dr. Juliana Alba. So while she gets her slides up. So she is a pediatric psychologist embedded within the Pulmonary Medicine Department at Children's Health Dallas. She earned her PhD in school psychology from the University of Texas at Austin in 2020. Her predoctoral internship at the University of Louisville, School of Medicine, Norton Children's Hospital, and her postdoc fellowship at Children's Health. She provides inpatient, outpatient, and consultative services for patients and families diagnosed with CF and other pulmonary diagnoses. Dr. Alba is especially passionate about working with underserved youth and their families, with a particular focus on working with Spanish-speaking families.
Thanks. All right. Well, I'm going to talk to you guys about something that I think is becoming more prevalent now that Trikafta has reached our younger population, and something that we're seeing a lot more in our clinic. I will be the first to acknowledge that I did not get into psychology to work with eating disorders, and I actually ran from it. And then I landed in CF, and I was like, oh, okay, great. So sometimes I feel like I'm learning as I go, but this particular patient, this is just a small snippet of things that we work on with her, but I just felt it was really relevant to a lot of the things that we're seeing. I have no disclosures. I am sorry about the blurry picture of our hospital. Our marketing team, I don't know, puts blurry pictures on the website. But Children's Health is smack in the middle of Dallas, very large metroplex in the state of Texas. We're a 425-bed hospital. Our CF center serves about 275 patients, give or take. And we serve a really wide catchment area for the DFW Metroplex. We are lucky to have Cook Children's about an hour down the road, but we'll get patients kind of from all around, as I'm sure they do as well. And we have a lot of rural areas in Texas that we serve, especially East Texas. Our CF team is growing every year, I feel like, and I'm just lucky to be one of the slightly newer members of the team. But we have pulmonologists, several GI docs, our nurses, myself, my 2 social workers, shout out, our dietitians, our respiratory therapists, our medical assistants, physical therapists, and our research coordinators. So we're quite a team, but that also means there's a big opportunity for us to collaborate. So the patient I'm going to talk about is a 14-year-old female patient who I've known since I've been at our CF center and started about 3 years ago. And I know her for a reason, but she's gone through lots of ups and downs. But she is being parented by a single mom, and she does have family nearby. She's got a grandmother and an uncle, but most of her life she's been raised by a single mom, and dad is not in the picture at all. They have limited financial resources, despite being commercially insured. She has Blue Cross Blue Shield, which we're all like, great. But, mom's little workplace in East Texas does not provide the best Blue Cross plan anyway. So they often struggle to, even pay for CF things. And even seeing me in clinic can be costly to them, especially if they haven't met their deductible, unfortunately. As I mentioned, they live in rural Texas, about 2 hours away from our clinic. And they do, come all the way to clinic every 3 months about, and when she gets hospitalized, which is a decent amount. She does have a history of ADHD, anxiety, depression. When I met her, she had been in and out of therapy several times. Usually she would fire a therapist after kind of getting annoyed with them. And she has a long history of being bullied. Middle school has not changed, as I've learned, and I feel like it's even worse in East Texas. So she was really bullied, especially by the girls. She's kind of more of an attractive, younger girl, and girls just don't like that, and she tends to prefer to be friends with males. She is on Trikafta. She takes it pretty regularly, we think. sometimes we question. She does have a pretty long history of non-adherence, and she gets hospitalized 2 to 3 times a year. She was actually just hospitalized a couple weeks ago. But for the most part, her lung function's pretty stable. Her weight and her growth have always been pretty stable. And we've never really had a ton of concerns about her physical health. It's usually her mental health or like the family's resources. But some of the things that we started noticing in clinic is that she was becoming increasingly preoccupied with her weight. And then mom started reporting that she was engaging in these disordered eating behaviors. So she was restricting unhealthy foods, so, chips, all the things teenagers eat, and I eat because they're delicious. But she was limiting her intake at times and going like periods of time without eating, and then would end up binging because remember, she has ADHD, so she's a little impulsive. So like truly restricting is hard for her. At one point she came into clinic and mom reported to the physician that, and showed the marking, but she had been using a belt and tying it around her waist, and tying it really, really tight so that she could try to reduce her waistline. And then she had also done things like take saran wrap and tie it around, or like wrap it around her thighs so that she could reduce the size of her thighs. So all of these things were really concerning to us, especially coupled with the fact that mom was a single parent and she'd been out of therapy. And, we were like, okay, are we seeing the emergence of an eating disorder? If we are, we need to figure out what to do because we need to stop it here as best we can. I will say, despite all of these things, she wasn't really experiencing significant weight loss, which was promising to us as a team. She'd kind of fluctuate up and down a little bit, but nothing that made us concerned about things like refeeding issues and things like that. So really, we were just kind of seeing these little behaviors, and we were like, okay, we got to nip it in the butt right here. This is not going to end well if we don't do something now. So like I said, I run from eating disorders, but she forced me to run into them. So I was going to talk a little bit about what the evidence-based practice is for disordered eating, which is different than an eating disorder. We've got some patterns, but not a full-blown eating disorder. No surprise, there's a lot more research in actual eating disorders, less so in disordered eating. I think it's becoming more of an emerging research topic, just with more knowledge of disordered eating patterns and how they can lead to future negative outcomes. But some of the main kind of evidence-based practices are psychoeducational interventions. So talking to people about disordered eating and what that means, longitudinally. Unfortunately, they've found that it does increase patients' knowledge of disordered eating, but it doesn't necessarily alter people's behaviors. And eating is a very social behavior. So that kind of makes sense to me. I will say there is an increased push for getting eating disorder prevention programs out in schools and doing some of this psychoeducational interventions in schools. Then there's dissonance-based eating interventions, and they've looked at these with disordered eating patterns specifically. And this is where you hold the two competing beliefs that they don't really seem to go together. So for example, women should be thin, but also should be accepted at any size. So these things are not two beliefs that are really congruent. But the idea is that if we can hold these two competing beliefs at the same time, our brain will kind of bring us to the middle. And so we're not staying at either extreme necessarily. So hopefully getting away from this thin idealization. And it has been found to reduce the thin idealization and body dissatisfaction, as well as dieting behaviors. There's usually an immediate decrease in disordered eating, and then there's also long-term decrease in binge eating behaviors. And then newer to the literature are things like emotion regulation approaches. So taking things from acceptance and commitment therapy, DBT, mindfulness-based approaches. These things have also been shown to reduce disordered eating and body image issues. And then I wanted to include this because this is something that we talk about a lot in our clinic when we are concerned about our patients and like their preoccupation with weight. Blind weights versus open weights. Truly, like the jury's still out. A lot of clinicians prefer blind weights, and that's because the literature shows that blind weights helps minimize patient anxiety related to the weight, and kind of reduces the focus on weight. And then open weights are more rooted in like exposure-based interventions where we're exposing the patient to the weight, and helping them kind of like come to terms with the number on the scale and be less anxious about what they're actually seeing. There's some qualitative data to suggest that patients really prefer the blind weights in the early stages of like eating disorder treatment, and then they like the open weights when they're later in recovery. So it just kind of depends, and it depends on like your theoretical background. The CBT clinicians prefer the open weights, but others will prefer the blind weights. So what we did in clinic for this patient. So we decided blind weights. This is a patient with a really long history of anxiety and depression, and so we wanted to focus on reducing her anxiety in clinic, and so we decided to do blind weights for her. She also did really become preoccupied with the number on the scale when she would come to clinic. So we documented that in what we call our patient review sheet. We meet every week as a team, and we review what's on the sheet so that we know what's coming up for the patients that are coming the next week. So that's on our patient review sheet. And then myself and our dietitian would always make sure to remind the inpatient team when she would get admitted that we needed to do blind weights at each admission. And that's just because obviously they don't come to our patient review, and we didn't want them to accidentally weigh her and then to, have to like mitigate some of those behaviors inpatient, because it makes it harder. It's usually a different team. We also decided we were going to minimize weight-based discussions in clinic, even from our physicians who, for a really long time, have liked to show the growth curve and, 50th percentile, right? We all know that. And so we decided essential information with mom only, and we weren't going to talk about the weight. And she did ask several times, what was my weight? And we would all just kind of like redirect. We'd be like, you're doing well, and let's move on. And then we would do I would do regular check-ins with her, usually every 3 months when she would come to clinic. And then the dietitian would also do regular check-ins with her and mom to kind of figure out what she was eating. She would do regular reviews of, nutritious food options and like balance, and it's okay to have chips and veggies and, all the good things. And then I would monitor her mental health symptoms and any of the concerning behaviors. I specifically with her, and also given her history of like ADHD, anxiety, and depression, did use a lot of the emotion regulation strategies with her. So a lot of acceptance and some of the DBT skills with her, because I felt like that would be really helpful. And again, this is a patient who had been in and out of therapy kind of unsuccessfully. So I was like, okay, we gotta really like focus on what's gonna be most helpful. In terms of the family, because we did ask mom to do some things, because of course eating disorders are not just cured in clinic. Parents have to do things at home, and same with disordered eating. We asked mom to increase monitoring and engaging her in mealtimes, so not letting her eat by herself, but having mealtimes with her so she could actually monitor what she was eating. And then also make sure like, maybe we remove the belts for a while and just see what she's doing. Like don't leave the saran wrap hanging around, things like that. We recommended an outpatient eating disorder therapist. She wasn't really at the point where like she needs inpatient treatment, but we thought somebody with an eating disorder background, because again, not an eating disorder therapist, would be helpful. That did not happen, unfortunately, due to insurance and time barriers. And then we talked about we would discuss inpatient eating disorder treatment in the future if things didn't improve and she needed it. So I wanted to kind of put it on mom's radar, because a lot of times when I've had discussions with patients who do need inpatient eating disorder treatment, it's very shocking, and families are often resistant to it. So I wanted to like slowly open up the conversation in case we did need to have that talk. So this is what happened. Over time, her preoccupation with her weight basically went away. And she stopped restricting. She stopped with her purging behaviors-ish. Again, she's ADHD and very impulsive. So like sometimes she kind of like binges, but she wasn't like purging with like saran wrap and things like that. She had improved self-esteem, which for this patient, it may also be confounded with her switch to homeschool. So she wasn't really being bullied as much anymore. And so that, I think, also helped with her preoccupation with her weight. And then she was a lot more present in clinic and participated a lot more. We do currently have some concerns. Like I mentioned, she's on Trikafta, and we've now sort of flipped to the opposite, where she's had a really significant increase in her weight. And so now we're, learning to like navigate those essential weight loss discussions, because she does. I mean, she's like off the growth curve now, knowing what her history was. So we're trying to be very sensitive about how we discuss her current weight with her and mom, because we don't want to like trigger past behaviors. And then the other concern that we constantly have is just her lack of interest in engaging with other mental health providers. She's not someone who does well virtually. And she tends to fire providers. So we've had a hard time getting her to providers in her community. And there are also not a lot of them. So some of our barriers are just, again, financial and insurance. Mom really does struggle. And usually part of the reason why they fire providers is not just her, but also mom's ability to pay the copay. The family's motivation to actually get more intensive treatment than just seeing me every 3 months in clinic or when she's hospitalized. And then her underlying mental health symptoms really drive a lot of this, and also are driving a lot of her current weight concerns. So it's always an ongoing challenge with this patient. And we all love the difficult patients, and I like particularly enjoy working with her. But we're not out of it. So we're working. And all right, questions.
So we recognize that we're at the end of our session, and it is over time. We will stick around to answer any questions that people do have if people want to stay. Thank you for attending. We're so glad to have so many people here today.